So I will be talking regarding dapagliflozin and SGLT2 inhibitors as a class in particular with regard to the emerging evidence and how this drug has changed the landscape of diabetes treatment. So as we all know, perhaps if you name a single drug that has actually transformed the way we treat and manage diabetes in the past decade is SGL2 inhibitors. From mere being a glucose lowering drug to continuing to progress the cardiorenal continuum that has been shown to improve with each passing year with the use of SGL2 inhibitors. So as we all know, when almost a decade back the molecules were launched, so they offered good metabolic benefits in patients with diabetes with A1C reduction of 0.7, 0.8%. But what surprise came is the publication of blockbuster randomized CVOT trials that perhaps for the very first time we have an agent which actually reduces your cardiovascular endpoints apart from giving you the glycemic benefits. Two distinct secondary outcomes came from the CVOT trials that they do improve heart failure outcomes and your renal outcomes. And from them, when the dedicated heart failure trials like the DAPA-HF or the Emperor Reduce or the Emperor Preserve, or even the renal trial like the Credence, DAPA-CKD or Emperor renal trial, when they were done, what they have shown is that they have robustly reduced the heart failure outcomes, the renal outcomes, which has never been shown with any drug in the past couple of decades. So I think that speaks volume about the efficacy, safety of the drugs. If you look at dapagliflozin as a class effect, it gives you A1C reduction to the tune of 0.7 to 0.8%. It offers you weight loss as well as reduction in the blood pressure, which may be clinically significant in addition to the what is offered by the antihypertensives. The metabolic, cardiovascular, and the renal benefits, they are usually attributed to distinct pathologic benefits and subcellular mechanisms in which these drugs improve the outcomes. So this perhaps induces diuresis, glycosuria, and natriuresis, and that leads to certain biochemical changes, including improvement in the mitochondrial and the cardiomyocyte bioenergetics, in which ketones is perhaps used in a better utilized way, so that the energy utilization becomes better. It improves your vascular function as well as the renal function with regards to decrease in the cardiovascular endpoints, renal endpoints, as well as the glucocentric benefits of the drug. What was could not have guessed at least a decade back that these drugs could be used for non-diabetic individuals, and by the virtue of dedicated trials, we do know that even in patients without diabetes, they are going to reduce the heart failure outcomes, they are going to reduce the renal outcomes. So these drugs perhaps have a dedicated benefits with regards to improvement in the metabolic pathways and the non-metabolic pathways through which they give you the dedicated cardiovascular outcomes. So not only the improvement in the glycemic status or the lipid parameters, they improve the visceral adiposity, they improve the bioenergetics in which how a cell functions, thereby giving you benefits with regards to heart rate, blood pressure, improvement in the cardiovascular outcomes. So if you look at the renal parameters, with that also, it induces the decrease in the intraglomerular pressure, acts as a smart diuretic, reduces the albuminuria, as well as there is certain evidences, especially in the experimental level, of chronic kidney disease. They have an excellent safety profile because of the less minimally with education and drugs at certain points. Glycemic decay is still very less, and there is special scenarios in which you can suspect glycemic decay. But the benefit which the give is something which is not offered by any other class of drugs. So if you look at the glycemic efficacy as an solo agent or as an add-on to metformin or other group of drugs, they give you glycemic benefit with regards to A1C reduction to the tune of -8 to 1.4%, depending upon what your baseline A1C was, that they can be added to any class of agents, including DP4 inhibitors, metformin, sulfonylureas, and insulin. The beauty of the drug is that the weight loss which the drug induces comes from the loss of visceral adiposity. That means if you offer the drug to an obese individual, they are likely to lose more weight. And if you offer the agent to a patient who is non-obese or even lean, they are likely to lose they are likely to lose less weight, and predominantly that weight loss is going to come from your visceral fat mass, not from your muscle mass. Hence, if you look at the dedicated CVOT trials, what we can see is that the DECLARE-TIMI, the landmark CVOT trial done for DAPA, that particularly represents the typical primary care segment patients which generally come to us for treatment, and these are the targets in which we can target for improved cardiovascular outcomes in future. The pumps, pipes, and filter. So we all know that SGLT2 inhibitors perhaps improve all the dedicated benefits with regards to heart functioning, the vasculature, as well as the renal outcome. So reduction in the MACE endpoint, but the subgroup cohort analysis, when they have shown that individuals who have a baseline ACVD, there they indeed reduce the MACE outcomes. But what was surprising is that there was significant robust reduction of hospitalization for heart failure and the renal outcomes, irrespective of the baseline A1C, glucose status, and the complication status. Fewer newer trials like the DAPA-HF, it is not uniform, but what they have conclusively shown that use of dapagliflozin in patients with reduced ejection fraction resulted in significant reduction in the first and the recurrent events for hospitalization. For heart failure, it improved the all-cause mortality, and there is a significant reduction in the CV death or worsening of heart failure even by 1 month of drug use. So by that, it is now well approved for treatment in patients of heart failure who had reduced ejection fraction. And this benefit was seen irrespective of whether you are a diabetic or non-diabetic on a baseline anti-diabetic therapy, what is the NT-proBNP level, or baseline EGFR. So across the class of agents or across the class of groups, this drug performed exclusively well. Now, if you look at, so this drug is now advocated to be utilized as a foundational therapy for management of heart failure. It is included in the guideline management treatment protocol for managing patients with reduced ejection fraction. And it is as good as ARNIs or other standard of care of therapy. And it definitely adds years to a patient life when they are initiated right at the proper time. Now came the surprise with the publication of DELIVER trial a couple of months back in 2022, in which they have seen whether the patients who have mildly reduced ejection fraction or even preserved ejection fraction heart failure, whether these candidates are likely to benefit with the use of dapagliflozin, because evidence for that was lacking. So what we have with DAPA-HF is reduced ejection fraction, but one thing became crystal clear with the publication of DELIVER trial, that it was perhaps the largest and broadest clinical trial of this population, enrolling high-risk patients with heart failure with mildly reduced or preserved ejection fraction. So in NEJM 2022, when the trial was published, it showed that dapagliflozin not only reduced the heart failure outcomes, but also it reduced the composite endpoint of worsening of heart failure and cardiovascular death in patients who had either a mildly reduced or preserved ejection fraction. And in Nature Medicine, only a month back, a meta-analysis came with included both the pooled meta-analysis of the DAPA-HF and the DELIVER trial, in which they have shown that perhaps you take into account any endpoint, the CV death, hospitalization for heart failure, all-cause mortality, or the composite of CV death or hospitalization for heart failure, all of these outcomes were significantly reduced with the use of dapagliflozin. Next, coming to renal protection. So DAPA-CKD was one of the very first trials to look for the use of dapagliflozin in both diabetic and non-diabetic, whether they improve your cardiorenal outcomes. So it was terminated prematurely because of the benefit it gave. So use of dapagliflozin in this particular arm in diabetic as well as non-diabetic improved 39% reduction in the composite endpoints of renal outcomes, especially more than 50% decline in the EGFR or ESRD, renal or CV death. And this also resulted in 31% reduction in the all-cause mortality. With this, it became that the drug is safe, efficacious to use, and the threshold of using the SGLT2 inhibitors, which was at around 45, 60, then 45, then 30, now became 25 with DAPA-CKD, and it was further lowered down by the publication of empiric renal trial, in which it has reduced to even less than 20. So dapagliflozin, one surprising thing I would also like to show you here is that use of dapagliflozin in these patients of DAPA-CKD trial, to look at the stratification by the ethnicities, we are surprising similar to what is found with other DP4 inhibitor trials that the Asian cohort performed very well and the hazard ratio was only 0.7 with regards to use of dapagliflozin and having a serious adverse outcome in the DAPA-CKD cohort. So by this, we know that use of the drug can be safe and effective in retarding the progression of diabetic kidney disease or even non-diabetic kidney disease, so that we have an agent as of 2022 that can actually bring some clinically meaningful differences in the life of CKD patients. I have not shown some subgroup cohort analysis. The two beautiful subgroup analyses have been published in which they have shown that patients who had FSGS and patients who had IgA nephropathy, which are distinct from diabetic kidney disease, in those patients also dapagliflozin resulted in lesser number of renal outcomes in patients who took dapagliflozin versus placebo. So not only the diabetic kidney disease, but per se other forms of chronic kidney disease, including IgA nephropathy and FSGS, these drugs work pretty well and can be safely prescribed. So one thought would arise that perhaps initial use of SGLT2 inhibitors in particular may give rise to sudden decline in the eGFR, but that is something which is very, very less in number, and usually once it can be monitored safely, majority of them do not necessitate reduction or omission of the drug. They can safely continue the drug so that they continue to get the benefit from the renal endpoints. However, the glycemic benefits are unlikely to be that bigger once your eGFR falls from less than 25. But definitely, I would endorse using the drugs if the patient continues to have some benefit from the cardiorenal outcome perspective. So what does the guidelines say? If you speak of in 2023, the combination, the ESD-ADA joint statement, which was published a couple of months back, they have clearly spoken that in heart failure or in patients of diabetes who are at risk for heart failure, SGLT2 inhibitors as a class should definitely be offered to them. And the drugs like DAPA, EMPA, or CANA, which have shown to improve the outcomes, should definitely be given even before metformin is given. If you look at from the renal endpoints, the change which I am talking about that earlier, the eGFR threshold is now reduced to less than more than, and continue to take the drug, and it should be withheld once the patient is initiated on dialysis or the patient undergoes transplantation. The use of dapagliflozin SGLT2 inhibitors in the PNDD, that is the new onset diabetes after transplant, is the data is very less but interesting, and I think within few years we might see the use of drug in post-transplant diabetes as well. If you look at the heart failure guidelines, it is recommended in patients who are at risk for heart failure, like a diabetic patients, or who have a pre-heart failure stage A, stage B stage. What is surprising to see is that if you look at the stage C and stage D, the robustness of data and the level of evidence for SGLT2 inhibitors is superior even with regards to or in contrast to ARNIs and ARBs, which have been the cornerstone or foundational therapy for heart failure. So I think majority of the heart failure patients would definitely benefit from the use of the drugs. So lastly, I would endorse the use of these drugs as per the KDIGO guidelines. So KDIGO guidelines as of 2022 endorse using the SGLT2 inhibitors in any patient, diabetic or non-diabetic kidney disease, if they are tolerant to drug, to initiate the drug if the eGFR is more than 20, and continue it until and unless the patient is supplemented with hemodialysis or the patient undergoes transplant. So I would like to summarize here that perhaps SGLT2 inhibitors as a class of drugs, they improve the glycemic control by with glycosuria, but the benefit which they give to the extra glycemic benefit with regards to cardiovascular and renal outcomes is something which is far, far superior, and no patient should be perhaps deprived from the use of SGLT2 inhibitors, especially in the off-patent era when the drug is available at much cheaper rate. So many patients who were deprived from the drug because of the cost issue can now reap the benefit of the drug. And dapagliflozin in particular, because of the publication of landmark trials like TICLA-TIMI, DAPA-CKD, DAPA heart failure, and DELIVER, it now covers the entire spectrum of cardiorenal continuum backed by robust scientific evidence to give you benefit with regards to extra glycemic benefit that is not given by any other class of agents as of 2023. So I would rest my case here and we can have some discussion.